Okay, I'm Dr. Stephen Vincent. I'm a vascular surgeon here. Anytime I start off the talk here, I sort of like to always give thanks to all those that have made sacrifices for me, my parents. That's my day I graduated from med school, my family, my wife and kids, and all those that know me know that I love to fish. So now the title of our talk is Peripheral Vascular Disease, an Overview. Okay, there we go. So I am from Detroit, Michigan. I went to a little country medical school called Wayne State, trained in a little country hospital called Henry Ford, and then moved down here. I don't have any financial disclosures or any special interests. So cardiovascular disease is the leading global cause of death, meaning around the world. And there's about, we'll just say 20 million deaths per year from reasons of cardiovascular disease. And 32% of those deaths occur probably in this country, and 1 in 3 as a result of that. So if you round that off, we could say probably someone dies from a cardiovascular event from every 34 seconds. When we speak of vascular disease, we're talking about blood vessels. And there's blood vessels, there's lymphatics, there's veins, there's arteries. We're going to concentrate on arteries because that's far most common cause of problems in us. And then if we look at arterial disease, there's 2 types of disease. There's what's called occlusive disease, when an artery nails down and loses blood flow, and there's what's called aneurysmal disease, where an artery develops a bulge in it. And this is just to show you what a normal artery looks like, and this will just let us know what the artery looks like once an aneurysm is formed. If we talk about arterial disease, it can occur at any level here, anywhere in the neck, the arms, within the chest, in the abdomen, or I'll refer to that as the belly, and the legs. And at any one of these points, you can develop a blocked artery or you can develop an aneurysm. We're going to concentrate on blocked arteries today. Now, people talk about peripheral vascular disease. It goes by many names. There's PAD, peripheral arterial disease. There's PVD, sometimes called peripheral vascular disease. And then some people call it POAD, peripheral arterial occlusive disease. And this here just gives us an idea of what a narrowing on an occlusion looks like. This is a blood vessel that has developed an atherosclerotic plaque narrowing, and narrows to the point that the blood flow shuts down. So before it narrows, this is what the artery looks like. That's a normal artery. You get buildup of cholesterol or lipids on the side of the artery. It gets progressive and ultimately ends up shutting down. So this is the normal artery. This is an artery with a narrowing, and this artery is narrowed to the point that it shuts off the blood flow, and you can see how that occurs. Now, what are the causes of blocked arteries or narrowing? Elevated lipids or cholesterol. And there's lipids, there are 2 forms you may hear people make reference to. There's cholesterol and there's what's called triglycerides. There could be scarring of the arteries from other reasons. Maybe someone had some kind of car accident and injured the artery and it was not recognized at that time. And then also, the body can also have just an effect in itself, what we call autoimmune disease, where it attacks the walls itself and narrows without plaque formation. But by far, the most common form of arterial disease or occlusive disease is going to be atherosclerosis. So if we look on this side of the slide, we'll see a normal artery, plaque builds up progressively. Same thing here, progression, it gets bigger, and then at some point it reaches what we call a critical narrowing, meaning that it narrows to the point that it restricts the blood flow. What causes this problem? Probably smoking is by far the most common cause. None of you guys smoke, I'm sure. Diabetes is another problem that plays a role in developing arterial disease. dietary habits, too many Big Macs to me, steaks, burgers, meat and potatoes. And then unfortunately, some of us may have some predisposition or genetic predisposition to developing narrowed arteries. So we call that atherosclerosis. And as we mentioned earlier, this is important for so many reasons. It can affect any artery in the body, arteries to the brain, to the heart, to the organs in your stomach, the kidneys, the intestines. And this slide here is just to depict, I'm sorry it didn't come out too clear, but this is the heart, and this is how an artery becomes more progressively narrow within the heart, and it reaches a point, it's so narrow that it restricts blood flow and the arteries shut down, and that's when a person has a heart attack. So let's start at the top, at the brain. The carotid artery, which is within the neck, this slide here depicts a nice, normal carotid artery. Over time, as we age, we develop this plaque that can cause a progressive narrowing. The symptoms of carotid disease can be multiple, but the most feared are stroke and what we call TIA. Stroke is defined as someone that may lose their speech, lose vision in an eye, develop paralysis or paralyzed arm, leg. Then there's also what we call a transit ischemic attack or TIA. Transit means it comes and goes. Ischemic means lack of blood flow. And what happens in this setting is that someone develops a temporary loss of blood flow in the eye. Someone tries to speak and can't get their words out. Someone maybe goes to reach to get their coffee cup in the morning and realizes that they can't hold it. They lose the grip, it drops. And then all of a sudden it gets better. We call that a TIA. And that usually clears within 24 hours. So now how do we diagnose this? First of all, physical examining a patient. I'm sure when you guys go to your doctors, they listen to your neck, feel the arteries, take all your symptoms, how you've been doing for the last year. Once there's a concern from a physical examiner from the history, then we get ultrasounds of the carotid arteries. And if we have certain findings on the ultrasound, then it may proceed to what we call some kind of contrasted study, such as now we call them CT angiograms, where you get dye installed into a vein and your body goes to the CAT scan and it gives us an outline of the arteries. Or sometimes we do what's called a standard arteriogram, where the doctor puts a catheter in the artery directly and takes a picture of the artery. So let's start with stroke. It's a medical emergency. It can cause significant disability to adults. It's suggested that approximately every 40 seconds in this country, somebody has a stroke. Now, if we look at how do we make the diagnosis of carotid disease? First, as we just talked about, we start off with an ultrasound. And this here is to demonstrate what the ultrasound is like. This is a person's head. This is the artery here. There's a technician that has a probe. The end of that probe, it has little crystals in it. And these crystals measure the blood flow as they go by, because blood flow, red blood cells have a charge. And then it's fed back into a machine that gives us information about the blood flow. If there's some concerns or findings from this ultrasound, then next it proceeds with some kind of contrasted study. And probably the most common one that we use now is what's called the CT angiogram, where an IV started, a person gets contrast into the vein, it travels to the body, and this CT scans it, and this gives us a computerized reconstructed image. So for carotid disease, there's two forms. There's what we call symptomatic and what we call asymptomatic. And in terms of treatment, I tend to be a lot more aggressive if there's symptoms involved. Symptoms being stroke, the TIA, meaning loss of eyesight, loss of speech, loss of use of an arm. And usually if there's greater than 60% narrowing, I will treat these people, and there's two modes of treatment, and we'll go over those in just a second. Then there's what we call asymptomatic, meaning that you go in, you see your doctor, the doctor may hear a little noise over your neck, they call that a bruit, sounds like a murmur, and so they're concerned, and then they'll order the ultrasound. The ultrasound gives information suggesting, well, there's what we call a significant narrowing there, and then that's followed up with some kind of contrast study. So for asymptomatic patients, I will only treat them unless, and I'll follow, meaning conservative treatment until they reach 80%. And then at 80%, we'll talk about some kind of intervention. So transient ischemic attack. What this slide here, I want everyone to get out of this is, if you look at this gentleman, he's experiencing a TIA, temporary loss. He's probably one that I can't see out of his eye, so he's covering the other eye to see if he can see. The young lady here, if you see her, you see the facial expression, you see drooping of the corner of the mouth. That's probably going to affect her speech. Then the other thing, it should be noted that this is a result of compromised blood flow, which allows blood clots to form, and this shuts off blood flow to a certain area of the brain, which leads to this here, drooping on one side of the mouth. So these are, if this occurs, these are medical emergencies and require immediate attention. So we treat carotid disease with what we call in a conservative fashion or observation. There's a list of things that I like to do. First of all, we talk about dietary changes in terms of, and I'm the last person that needs to talk about dietary changes, but we talk about them to control the lipids, to try to get them under control. And that also may involve what we call anti-lipid therapy. In other words, some kind of medicine that we can use to bring the cholesterol down or the triglycerides down. Then we always talk about exercise is a hard one because, as we get older, arthritis plays a role. It's harder to walk, it hurts. We become less mobile, but I think is pretty important in terms of preventing progression of occlusive disease. And diabetes is another one. Unfortunately, a lot of patients that will have this, what we call arterial occlusive disease, the diabetes is out of control. So bringing the diabetes under control helps prevent progression. And so this slide here is just here to depict the progression of disease. This is a normal artery. And then what happens is the artery develops a little injury that heals by the deposits of fat on the side of the wall. That fatty material can get bigger and bigger, as you can see. And as we talked about, it goes on to become what's called a critical narrowing that shuts down the blood flow. That's what this last slide. And then the last and probably the most important thing is to try to convince patients to stop smoking. And that's a hard one. So if it gets to a point that we're going to consider some kind of treatment, we call that an intervention. And probably treatment is moving towards what we call carotid artery stenting. Basically, it's done in our angiographic suite. The patient's lying flat on the table. We call that supine. And the artery is accessed at some point, either in the arm or in the leg. And then we put this catheter in the artery. Now, this is the carotid artery. This is the plaque in the carotid artery. Now, you can look at that and you probably say, man, you put a balloon up there, I bet some of that breaks off and goes to the brain and cause something bad to happen. And it can. So what happens here is we put a little protection device up right here. Looks like a little umbrella. And as we're working, if anything breaks off, this thing will trap it and keep it from going to the brain. So first we put this in, then we go in with a balloon and open this up some, and then we go in with a stent and place this stent, and this stent works as a scaffolding. So in other words, we have this really thick plaque. If we open it up with this balloon, the tendency is for it to collapse down again. So this stent stays there to prevent it from collapsing. And so then once the stent's in place, we take a picture, make sure everything's okay, and then we retrieve this device and pull everything out. So this is me doing probably one of the first ones in Columbus. And this was the artery here. And this is where you can see how bad that looks. That's nastiness. And then, we put a stent up there and you get a nice smooth result. The other option is what's called carotid endarterectomy. So the carotid arteries in the neck, we make a small incision about 3 inches in the neck. We expose the carotid artery. Everything's here exposed, so you don't have to go through that part. And then once the carotid is exposed, we put a little device in. You probably think, well, what happens to the brain if you shut the blood flow off to the brain? Doesn't the patient have a stroke? That's what happens. So then somebody got smart and developed this little device called a shunt. So we put this shunt into the artery here and here. This shunt carries the blood to the brain while we're working to prevent strokes, and then we clean the plaque out of there. So this is, I wish you could inflate that, but this is the plaque here, and then this is the artery once it's been cleaned out, and we sew in this little piece of material here. It's called a patch. It's like when I was a big kid, you know, I split the pants. My mother always put this little patch in the seam to keep them from splitting again because I had a big butt. So this thing here keeps this from narrowing down again. Okay, so, you know, and it's been proven to be effective. So I show this slide here. This is what we get out when we clean the carotid artery out. And if you see this here, that's a clot that's probably formed as a result of the blood flow being restricted. And you can see if you have this here, how this can easily break off and go up to there and cause a problem. So we'll go to what I call the extremities next. And what I'm going to say for this, because I was asked to try to keep this under 40 minutes, so we can't get everything. So what I'm going to say here is everything that occurs in the leg can occur in the arm or vice versa. And what I'll say is leg problems are much more common than arm problems. So we'll concentrate on the leg. But this is the anatomy here. The leg here comes from a large artery called the aorta. It branches off, comes down and branches multiple times and ultimately gets blood flow down to the foot. The same thing occurs here in the arm. This comes from a large artery called the aorta in the chest, comes down multiple branching points until blood gets down to the hand. If we look at disease or problems of the leg, it can occur at segments. And from the leg, most of it starts right here. And I showed this so everyone will have a sort of an idea anatomically where we are. This is the abdomen, or I always call it the belly. This is the aorta. It comes down. It gives blood supply to multiple organs, the kidney and the GI tract and all those things. And then once it gets down to a certain area, it splits. One side goes to the left leg, one side goes to the right leg. And then this is the aorta branching coming down to the leg. It forms these arteries called iliac arteries in the pelvis, and in the groin, we have what's called femoral arteries, and then it comes down to the behind the knee and forms what we call popliteal arteries, and then arteries all the way down. So now, what kind of symptoms do we have with the legs? The most common symptom that we encounter is what's called claudication. And claudication is derived from a Latin word that means pain. Then, more severely, we have what's called rest pain. Rest pain is defined as the circulation has become so bad that when a person lies down flat, they lose gravitational blood flow to their limb. And so to take the pain away, they sit on the side of the bed, hang the leg down, and blood flow will improve based on gravity and take the pain away. Then next we have what we call ulceration. An ulceration is just a fancy term for a sore. And then the last most feared thing is gangrene. So you can see again, just like in the carotid artery, we have this plaque here, and it's gotten progressively narrowed to a point that it leads to a critical narrowing or critical restriction of blood flow that blood cannot get down to that leg or hand. So we'll start off with what we call claudication. The true term is called intermittent claudication because the pain's not there all the time. It only comes when people walk. So, you know, the person comes in and says, you know, doc, I parked and anyone that see me, I always have my standard is, I always ask, can you park your car at the end of the parking lot at Walmart's or Kroger's, because everyone goes there. And if you park there, can you walk in without stopping? And I use that as a test in terms of how bad their symptoms are. So if I'm walking and the artery is blocked in my thigh here, say I'm walking here, so I have a blocked artery here, and so I walk and then I get this pain in my calf, and they'll reach and grab and stop and rest. The pain goes away, and then they start walking again. The pain again resolves. That's why it's called intermittent claudication. And what happens when this artery is blocked in this thigh and the muscles generate all this energy, they need oxygen and other nutrients to get down there. Well, if the artery is blocked, it can't get down there. So what happens as a result of that, the muscles go on a special type of what we call metabolism. It's called anaerobic metabolism. And during that, it produces acid. And the acid causes burning and pain in the tissues at that point. If they stop walking, that acid is washed out and the pain resolves. So that's why it's called intermittent claudication. And, the other thing that patients will say, doc, I walk okay, but when I try to walk up a set of stairs or an incline, it really gets hard and I get pain. So that's claudication. And this gentleman here, he's walking, then all of a sudden he gets the pain. He has to stop and rest. And then once he's had a period of resting, the pain goes away and he starts to walk again. This is called rest pain. And I have this slide here because patients come in, they tell you, well, doc, I go to bed, I get pain when I walk, and it occurs at a very short distance. And so then my next question is, I ask them, does your pain get worse when you go to bed? Because classically, people will lie flat. Again, we talked about it. If the circulation is so bad, they can't get blood down there. And so then the same reaction that occurs when a person's walking happens when they're resting. And so they find quickly, if I sit on the side of the bed and hang my leg down, the pain goes away. So a lot of times these people will come in and see me because they've been sleeping in the chair, sitting in the chair all the time with the leg hanging down to deal with the pain. They come in with big swollen legs because of this, what we call dependent edema. And this improves the blood flow slightly to take the pain away. Then the next thing, what we call, it's called an ulcer, but it's basically a sore that occurs for whatever reason. This is a lot more common in diabetics. Ill-fitting shoe. Perhaps maybe sometimes patients may have, they can't really sense their legs. They have neuropathy for whatever reason. And they may have a rock in their shoe, or they step on a pebble, don't realize it. And then all of a sudden this doesn't heal because they don't have the blood flow to heal this. And this is what it looks like right here, right here. And it most commonly occurs here because, if you think of the foot, there's like a knuckle there and it's a pressure point, and that's going to be the weakest part of the skin to break down. And then the most feared thing that we see that patients are really concerned about is gangrene. And this is what it looks like. You can see the discoloration of the tissue there. I have to be honest, I'm just amazed sometimes how often this can be ignored. I'm not bragging, but I'm very thorough, and I make everybody strip down, take socks off and everything when they come in. And people complain about it, but I can tell you, way back in my experience, a long time ago, I was in practice in Virginia, and it was sort of rural, and people didn't have a lot of medical care and so forth. And I walked in the room and really smelled something bad and didn't realize it. And I had no idea how this could have gone on so long. So then I take this sock off, and then this is literally what I saw in this patient, and no one ever recognized it. It sort of befuddles me, for lack of a better word, how these things get ignored. And sometimes I think us as human beings sometimes think in ignoring the problem, sometimes it will go away. And then sometimes symptoms are ignored, they get better, and they come back and they don't get addressed until the symptom becomes really, really bad. But this is an unfortunate thing. But if we catch it at this stage here, like this, there's a lot of times we can help people. So now, in terms of diagnosing this problem, again, the history and physical exam, talking to the patient, asking them all kinds of questions. And then once we've completed our assessment or the appropriate testing, which is a Doppler test, we always start off with doing some kind of ultrasound to assess the blood flow down to the leg or the arm. And then some kind of contrasted study, meaning the person receives dye, the outlining blood vessels to show me where they're blocked open, and we can talk about what we can do to try to make it better. This guy got cold feet for his wedding. Did you guys read it? So in terms of the lower extremity disease, the first thing we order to assess a person for claudication, rest pain, ulceration, breakdown is some kind of Doppler test. And this is what the Doppler test looks like. This is an older thing. We don't do this a lot, but this is called segmental pressures. And this takes a set of blood pressures at every point in the leg, and we take this information and we can sort of get an idea of what point the blockage is. So if we look at this, and I always like to do both sides so we can compare them, but if you look this is what we call a waveform indicating blood flow. You can see this one's nice and strong, and you can see this one is sort of weak. It doesn't have any peaks or anything. That indicates that something bad has gone on. And if we even go further down at the ankle, if you look at this here, and look at this there, you can see a significant difference. So the other tests we do are what's called segmental pressures, where we'll take a blood pressure in the arm, we'll take a blood pressure in the leg, and we'll take a ratio, and there's a number that we use that we like to have. And as part of that also, that same test with the ultrasound on the neck called the duplex scan, we do that on the leg with the ultrasound transducer here, looking at the blood flow. You can see this thing picking up the sound waves. That's what that's supposed to imply. And then it gives us information back, gives us an idea what the blood flow, and also this color here gives us an indication of how much blood flow is getting through there. So the next thing that we would get will be some kind of contrasted study. And most of the time, almost everyone gets we'll say there's a blocked artery, we need to fix it, I need to consider fixing it. We'll get what's called a CAT scan or a CT angiogram, where you get an IV, you get dye into your vein, it travels throughout the arteries, and then this CT scan senses this and gives us a nice image of what the artery should look like. Now, this is a normal one, but the beauty of the CAT scan also is we can get multiple views, like, we can get straightforward views just like this, or we can get views like if you, for lack of a better term, would cut a person in half and look down in it. And that's what's occurring here. You're looking straight on at the patient here, and these here is slices at every level. So now, next is what we will call conventional angiograms, meaning that a catheter is put into the artery, and through that catheter we inject dye, and this dye then follows the outline of the artery, tells us where it's blocked, where it's open, and it will tell us what options that we have to try to make this better. And when we do this angiogram, it can be done several ways. One, we can access the arteries from here in the wrist. I don't know if anyone's ever had like heart gas or anything. You can go from the wrist, or either the other option is we can go from the groin, and we can get these pictures. And the beauty about this here, doing it this way, is sometimes we can fix it at the same time, and you'll see this on the next slide. So now, let's say, for instance, we want to treat, we talk about there's aggressive and there's conservative treatment. If we're going to treat this aggressively, conservatively is why 60% of people, from my standpoint, will respond to conservative treatment. So for someone that has what's called claudication, the first thing is stop smoking. And that's a hard thing. It's really hard to get people to stop smoking. Then the other thing will be dietary changes in terms of low-fat diet, watching the things that you eat, getting patients on an exercise program, daily walk. And I tell patients you can't go out and run a mile, but maybe walk a half a block every day and then increase it by another half a block every week until you build up your tolerance. And then lifestyle changes in terms of what that means is being more active, not necessarily going in and eating dinner and watching TV, maybe eat dinner and go out for a walk or walk around the backyard. And then there's medications that we can also use that can help improve the blood flow. Somehow people think they stop smoking when they start vaping and that makes it better. And vaping in itself has a whole nother set of problems that it can cause. So one of the medicines that we use to treat this is called Platol, but the trade name is Celestazol, and it works by what we call relaxing. A blood vessel is a muscle. This medicine causes this blood vessel to relax and dilate and get big. So this will be a normal blood vessel here, and then this will be a dilated blood vessel. And when it dilates like that, the idea is that it will allow more blood to get through, to get to wherever it's trying to get, whether it's to the arm, the leg, the kidney, or whatever. And by doing that, as we talked about, being able to get nutrients and oxygen to a certain area to prevent this shows increased transport of oxygen, nutrients, and glucose to carry out these reactions when the muscles are working. So how do we treat vascular disease aggressively? So first of all, a lot of it can be done catheter-based. When I finished my training back in, that would have been 1985, almost everything was done operatively. Well, there's been a lot of advances over time, and probably 60% of it can be treated with catheter-based studies. And so the way that is done is that we access an artery, most of the time in the groin, but like I said, sometimes it can be done in the arm. And once the catheter is in the artery, we take a picture, and this is the artery here. You can see the artery is blocked. This is the big artery, the aorta. You can see there's one artery here. That's an iliac artery on the right side. And you can see on the left side, you don't see anything there, right? So that's the blockage. And then as you pay real close attention, you see that the dye starts to reappear here, and it's filling through what we call collateral circulation. So there's a lot of techniques that we can do to open that artery without doing an operation. So this is one patient that had this exact problem, and we're able to get it open and improve their symptoms. So that would be called catheter-based treatment. The other way that we do it, and I'm a surgeon, I like to operate, but open surgical procedures, and I put this picture here so we can get an idea. This is the aorta, this is in the belly of the largest artery, and that gets blocked a lot of times. One way we treat that when that aorta is blocked is we do a bypass. So we see this aorta, then if it's blocked here, if it's open here and open here, we take a piece of material called Dacron, it's a graft, and then we sew it in above the blockage, make tunnels, and then sew it in below the blockage, restoring blood flow to the patient's leg. Then in the leg, there's arteries, and they can become blocked. And so we treat those in the same way. We can open them sometimes with catheters, but other times we have to open them with surgery. So this here just shows the different levels of blockage that we have. The artery, this is the normal artery here, called the femoral artery, that comes down and forms other arteries, the popliteal and arteries down here. So if this artery is blocked here, we can do a bypass, sew it in above here and then down here, bypassing the blockage. There's a number of types of materials that we use. Most favorably, the one that we like to use is one's own vein, but then sometimes we use synthetic grafts made out of a material called Gore-Tex, a polytetrafluoroethylene. And this here is just to give you an idea of what we're working with. When we're doing these operations, I have to wear magnifying glasses because we have to do this little fine suturing here to try to connect these blood vessels. Thanks for coming, guys.